I think Hopewell towards addressing these imbalances that have been created. And while we are struggling to say we need to correct the funding model that has been used since 1994, post democracy, we then found another major challenge, which is facing the very same overburdened public health and under resourced, being our illegal immigrants. And for instance, when one was interacting with the patient, because sometimes you assess the level of literacy of a patient, and then you want to go to that patient and explain some of these things, because you can see this person can be able to understand what you're talking about, so that they don't go out and say, but South Africans are unfair, South Africans are that. Now, one of those explanations was just to simplify that you have got Stats SA or census here, where they will go around counting us and be able to come and tell you that Limpopo, you've got so many population, and presenting those statistics to the National Treasury, which will then look at its fiscus and then allocate budgets based on the data that is available. And our province, it's not same as Gauteng or KZN or Eastern Cape in terms of the citizens. We are lower than them. Then the budget will talk to those legal or people who are in the country, documented. Let's use the word documented, and it will give you the understanding to say how many citizens do you have and how many documented citizens you have. Now you are given this particular budget to address that. And then already with the budget that you are given, you are already complaining that this budget, it doesn't meet the demands. Already I've shared with you the broader challenge of funding of healthcare in the country. So on top of it, you are hard hit as the public sector, because the budget that you are then given, it's based on the population that is available. And the undocumented, when they enter the country, they will never be accepted in the private healthcare. That we know it's a fact. Because even South Africans, when I am sick like this, if I go to the private healthcare, even if they are the ones who are now raising the issue that Section 27 talks about access to emergency healthcare, we don't see that in practice in the private sector, to say, even if it's a South African citizen involved in an emergency motor vehicle or in labor, you go to that facility, you either must put upfront the money that you have, or secondly, if you have a medical insurance, they must be able to prove that there is authorization. These days there is even pre-authorization before they touch you. So, but then when it comes to the state, we do our things differently. What we want to also put it up front, it's that people must understand, and I think we can all agree, and this is also applied to us South Africans, is that everyone must pay services. There are two categories. You have got a primary healthcare where it's free at the point of entry, which is the primary healthcare, where you go to your clinics, you get immunization for your children, you do your antenatal and even deliveries at the clinics. You get your vaccines. We're not paying at that level. It's free primary healthcare services. It's funded by the state. When you move to the hospital level, which is where people do not really are failing to understand, when you get to the hospital, you must pay, because you are now entering a secondary and a tertiary services. And how does the system work for you to pay? When it's me, Poppy Ramathuba, because I am at a certain economic class. When I arrive there, I go through a means test, and I'm told you are at H3, meaning you are earning above 72,000 per annum, or you've got a medical insurance. Then you will cover full payment. Or they will say you are what we called H2, meaning you are earning up just above 35,000 but below 72,000. We're going to make you to pay a discounted fee. When you are now below H2, that you are earning below 35,000, you are H1, and then you will also pay a minimum discounted fee. Then, but when you are H0, this is where the problem is. When you are H0, from a primary level up until tertiary services, in academic center up to central and academic hospitals, you don't pay when you are H0, because you should be able to prove that you are unemployed. And how do you prove that you are unemployed? You either bring an affidavit from the police where it will be a sworn one, or you are going to go to, if you are getting a grant, pensioners for the social security, you must prove using a receipt that you earn that amount, and then you will then be able to be assisted without paying. So this means test function properly for all the citizens and for all those who are documented. Now the challenge becomes when you are not documented. This is where the overburdening of the system comes in. You are not documented. Some of the undocumented foreign nationals do not even bring an identification document, maybe your own ID or passport. They don't even have those documents. Now we do help assist them, but we are unable to build them or to classify them. This has got its own repercussion, because when the Auditor General audit us and we are saying to them, we can't collect this revenue, we must prove why this person cannot pay. As it is for now, we are owing, or we are being owed by patients more than 500 million rands, which must be written off. Since my appointment as an MEC, I have already make a requisition of writing off of more than R1 billion of patients owing fees. Now, when you ask Treasury to write off those debts, they want to see the proof. Was it a pregnant woman? Was it somebody who was a pensioner? Was this person unemployed? So undocumented immigrants do not won't go to the police to get that affidavit, because they're afraid they might be arrested. Now, what they do, they come in and give us false information, some of them. When they give us the false name, we, upon discharge, when we try to collect this debt, or recover the debt, you find that the information they've given us, the address, nothing works, nothing functions. So already as I speak, our National Treasury appointed a team of some service provider to help us with the collecting of this debt. They were sharing with us that only 10% of the 500 million, they do have a potential to can trace. 5% they've already traced. The remaining 9%, which is 450 million, it must be written off. Mind you, the budget that we get, there is a portion that is attached to revenue collection. I've already forfeited that. Because of the challenges we're facing with COVID and that, we receive a budget cut of 3 billion as a province. Now, I'm giving you this financial complication so that we must understand and appreciate that when we come to the province and refuse to pay, and also our neighboring countries refuse to pay when we appeal to them to say, embassies, please reimburse. These services were consumed by your citizens. Remember, I know of our constitution, it says health is a basic human right. I want to believe that any country must take health as a basic human right. And I think COVID-19 taught the global community that. So if a nation is not able to provide the health care to its citizens, the best they can do is to reimburse those that are doing that particular work on their behalf. Because human beings are human beings. Life is life. When the healthcare workers sees you, see a patient, they don't see the nationality. That's a fact. It will be only us who are policymakers who are supposed to help the healthcare workers to collect this revenue so that we can continue to render these services. We have recently, I was with a forensic pathologist trying to do an analysis of all the unidentified or unclaimed corpses. Just for forensic only, we have already buried as a country 349 unclaimed bodies, unidentified. Because these are the people, I've not included those who died of medical conditions in our hospitals. These are the people who come and give us false information. And when they passed on in our care, we are unable to trace their families and their next of kin. And you'll find that the corpses can stay in our mortuary for more than 6 to 12 months. And from there, they must write to me. For instance, in Chilizini, we just disposed corpses last December, but I'm told now we already have another 44, which the process now, the procedure says, I must go to the municipality and 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 buy the graves, go and buy the coffins and come and bury. This is not the money that when treasury allocates, will look into that. So it has put a strain even on our forensic services, such that you will see that even the post-mortem turnaround time has become even slow. The mortuary, at some stage, you might have read headlines to say mortuaries are overflowing. There was a case wherein a patient died around 12 midnight. The procedure now, because we no longer have those, our mortuaries are full by the unidentified bodies. Then what happened is when you die, we must call your family, if you are a local, to bring an undertaker at 12 midnight to come and collect your corpse to go and put in the private undertaker. Now, when the person died at 2, and we know that's the time where most of the people died at midnight. That was my experience. Most of the children are born at night and towards the early hours. So life and death, it's around midnight towards the early hours. Now, our nurses get traumatized by having to leave that corpse until morning when the family comes to claim. And this is a corpse. That's a story at Philadelphia Hospital. The corpse had to sleep with other fellow patients. Now that is the unhumane part of it, where we are being subjected by this current system to say, when the staff leave a corpse that has been wrapped to wait for the family to come because there's no any other place to go. What about the emotional challenges that will face the fellow patients who are alive? And they must be sitting to say, it can be me. They then begin to lose confidence and stress develop, and even the treatment will not work on them. So that is why we're saying if we can get cooperation from our neighboring countries, and you rightfully put it, Hopewell, to say people might think we are attacking Zimbabwean national, and I need to clarify this from upfront. As Limpopo, you have said, we can't change the fact that we share the geographic location and our border post with Zimbabwe. As such, that is why when you talk about illegal immigrant, every second patient would be coming from Zimbabwe because we are their nearest. For them, if they need health care, if a woman is pregnant and she wants to deliver her baby safely, she will have to cross the border to come to the province, and which will be Limpopo. And that's why you hear Musina Hospital. It's one of those hospitals that is really hard hit, followed by your Chilidzini, your Silom. These are some of the hospitals on N1, your Louis Trichardt Hospital, your Butlokwa, on your N1, because sometimes when they are making their way to Gauteng and other Cape, other provinces, they might fall sick and they will have to be assisted there. So all we would want to raise here is that the challenges that is being felt by the system, it had its own challenges that it was trying to address. But these challenges are not, the results of us trying to turn around the system are not becoming visible because we have to carry the burden of undocumented foreign nationals, which their states do not really want to come on board and assist us. So if you go to another province like Mpumalanga, it will be a different story. They will not be talking about Zimbabwean nationals. Perhaps you'll hear the other nations complaining that Mpumalanga is attacking us. If you go to Free State, they will be talking about Lesotho. They will think they're attacking us. So what we're simply saying is that South African healthcare system cannot, and it will become impossible for it to carry the entire continent in terms of the healthcare system, or even SADC, because we also equally have the Pakistan nationals. We also have the Somalian nationals. They're there, and they're undocumented. We are having to deal with them, providing healthcare for them. If they can't pay as individuals, their state, I still strongly believe, should be able to meet us halfway.